Good evening, sir. First of all, happy Teachers' Day to everyone.
Thank you.
Thank you, sir, so much, my child.
Can I start, sir?
Please.
I'm presenting a case of a 43 years gentleman named Mr. XYZ, teacher by occupation, residing in Kengeri and belongs to upper middle class according to modified Kuppuswamy scale. Chief complaints dilated veins in the right lower limb since 3 years, pain in the right lower limb since 1 year, blackish discoloration of skin over right ankle since 3 months. Patient was apparently well 3 years back when he noticed dilated veins on the inner aspect of the right lower limb. They were insidious in onset and gradually progressive in nature. They increase in size on prolonged standing or walking and decrease on lying down. They are associated with intermittent episodes of dull aching pain since 1 year in the right calf and the lower leg, aggravates on prolonged standing and walking and relieves on lying down, not associated with night cramps. The patient also noticed blackish discoloration of skin over the right ankle 3 months back, which was insidious in onset, gradually progressive, not associated with itching. No history of edema of the leg, fever, abdominal distension, pain, and chronic constipation. No history of breathlessness, cough, hemoptysis, trauma, prolonged immobilization of the limb, non-healing wound in the lower limb, previous surgery for varicose veins, and long-term hospitalization. Past history, no history of similar complaints in the past, no history of diabetes mellitus, hypertension, asthma, epilepsy, tuberculosis. Treatment history. He has been using compression stockings for the past 3 years. Personal history. Diet mixed, appetite normal, sleep adequate, bowel and bladder habits are regular, no addictive habits. Family history. No history of similar complaints in the family. Summary. A 43 years old gentleman, teacher by occupation, presented with complaints of dilated veins on his right lower limb since 3 years, which were insidious in onset, gradually progressive, increase in size on prolonged standing and walking, and decreases by lying down. Associated with intermittent episodes of dull aching pain since 1 year. He noticed blackish discoloration of skin over right ankle 3 months back. There is no history of major ailment in the past, and there is no history suggestive of deep vein thrombosis. From the history, I can conclude this is probably a case of varicose veins involving the great saphenous vein.
Yeah, Saniya, it was a
Good presentation.
clear and good presentation. Can you come back to the first slide so that we can have a little discussion on the history?
Yes, sir.
Okay, fine. Anything you would like to highlight with this gentleman's occupation?
Yes, sir. He is a teacher by occupation. Varicose veins is more commonly seen in occupations which demands for long hours standing.
So you think probably he is a risk candidate for developing varicosity?
Yes, sir.
Am I right?
Yes, sir.
Okay, fine. If he says, this teacher says, no, I don't stand in one place, but I move around in the class and I take the classes. And this is my habit last whatever the years he is being teacher. And this he does 6 to 8 hours every day. So will, in spite of this information, will you take this gentleman as a risk candidate for developing varicosity?
Yes, sir.
Okay, why do you think so? If he is moving around?
Even if he's moving around, still somewhere in between, he would have stood. No, sir.
No, he denies that. He denies. Whenever I go to class, if it is 11 to 12, 1 hour, I don't stand at one place. I move around and I go to the student's place and I speak to them and I take the class. So will he become a risk candidate? Okay. See, it is standing in the sense, it is there has to be some stagnation of blood in the lower limbs.
Yes, sir.
so that the gravity acts and there should be a column of blood constantly, maybe in the sense, constantly in the sense, not necessarily 6 to 8 hours, majority of time. If there is contraction of limb muscles and this, there won't be any stagnation, there will be pumping action and they may not be very much risk candidates. Okay.
Yes, okay, sir.
This is for information. Yeah,
Okay.
overall, according to the literature, teachers are risk factors for developing varicosity, like we doctors. But you should know this.
Okay,
Okay,
sir.
fine. Next slide. Okay, how did he come to know that he has got dilated veins?
He actually noticed multiple irregular swellings on his legs, sir.
Okay. Any other differential diagnosis if you take only this chief complaint, or straight away you think only it is a venous disorder?
I can think about cellulitis, sir, if there is lymphatic.
No. He has got swellings, multiple swellings in the limb, or directly he said they are veins. Did he say that, or he said swellings?
Swelling, sir.
So cellulitis will not present as multiple swellings. Cellulitis will present as swollen limb. Swollen
Okay.
limb is different, swellings are different. So you should keep multiple lipomas as one of the possibilities.
Okay, sir.
Okay. But since he says in the history you have described that they come down or they disappear after lying down after limb elevation, so straight away that fits into venous system, which may not happen in lipomas.
Okay, sir.
Okay. Okay. And you said the pain, no? Can
Yes,
you
sir.
describe little more about this pain? What exactly, how exactly? Don't go to the next slide, you describe.
So the pain was dull aching, and it aggravated when he walked for a long distance. And it was just intermittent episodes. When he used to walk, that time he had pain. And the pain was localized in the calves and the lower leg.
So the description what you are giving, why not this could be a case of claudication?
Sir, it is not associated with night cramps.
Okay.
And there
Fine.
is it is dull aching pain.
What you described was typically like a similarity of early claudication. While on exercise, when you start walking, there was playing, isn't it?
Yes,
What
sir.
is the typical venous claudication pain? If it is due to venous insufficiency, you will get pain when and how it gets relieved.
It gets relieved on lying down for 15 to 30 minutes. Sir.
Lying down and lifting up the lower limb.
Elevation of the lower limb.
And it is usually at the end of the day.
Yes.
Yeah, but here you are giving the pain which you describe, as I said, looks like a arterial pain. The patient walks on exercise, he gets pain, then slowly it gets disappeared, you said.
Yes.
And typically in the calf region,
Calf
this patient
region
also.
only, he said.
So all the description what you have given, it fits into the arterial disease claudication. Okay.
Okay, sir.
Yeah, he may be having the symptom, same symptom. But what I insist, when it is asked like this, you should be in a position to substantiate. Okay. If you take only the pain factor, this may mimic with the arterial disease, like getting more in the cough, the intermittent pain, and it increases on walking. So it goes in favor of a claudication, arterial disease. But in a venous disease, if you really want to explain this, how will you substantiate? One is you said the pain get relieved after lying down or elevation, more specifically. What happens to the arterial pain if you elevate the limb? If it is a arterial claudication.
The pressure in the limb increases.
Now, what happens to the pain after elevating?
It gets aggravated.
Aggravated. Okay, here it gets relieved. What happens to the pain if the limb is hanging by the side of the bed in arterial disease and a venous disease?
In arterial disease, it gets relieved, and in venous disease, it gets aggravated.
What is the reasoning?
In venous disease, there is peripheral pooling of blood, sir, because of which there is a chronic venous hypertension. And because of the chronic venous hypertension, there is transcapillary leak. The fibrin gets deposited around the capillary, and there is it forms a capillary plug, fibrin plug, which prevents nutritional exchange. So there is hypoxia, and that explains the pain.
Yeah, very good.
In arterial disease, why it gets relieved?
In arterial disease, the arterial pressure, it starts increasing, and there will be
why arterial pressure starts increasing in the limb lying down? Because of gravity.
Okay, sir.
Okay, because of gravity it comes down. So relatively there is a little improvement in the arterial supply. Relatively, the vessels may not open up, blocked vessels, but relatively there will be increased volume of blood, arterial blood in the hanging limb. So they get a transient relief of pain. How will you differentiate from a neurological pain?
Neurological pain.
You have three types of claudication, isn't it? Arterial, venous, and neurological claudication. So Sarah is asking, how will you differentiate? Yeah, somebody has put the chat box. Pain on the first step.
Okay. So
you have a compressive type of pain in the arterial claudication, and the classical description is bursting type of pain in venous claudication. Okay. Right.
So this is how we differentiate between three types of pains. Okay, one more to add to that neurological pain, it can be sometimes a radiating pain, which is unlikely in both arterial and venous disease. So if a person gives a history of radiation from above downwards, typically that goes in favor of a neurological pain. Okay, so that is how we differentiate between three entities. Now, you have described blackish discoloration. I am not happy with the word which you have chosen. You know why? Huh? Yes, sir?
Yes, correct, sir.
Yeah. So what may be the reason why we are not happy? Sir also is not happy with this terminology which you have chosen to describe this patient.
I should have mentioned pigmentation of skin.
Exactly, yes. Or discoloration, that's all. It is not black. It is something other than normal.
Okay, sir.
That's right. That's exactly happens in a venous disease. That too around the ankle. Why around the ankle typically?
Because the number of perforators in this region are more, and the foot mechanism is that the pressure from the foot is transmitted to the superficial veins during walking, sir.
No, that is, there are not many veins on the dorsal arch, like there are no communicating veins, there are not many. Yeah, here directly the skin is there, not much subcutaneous tissue around the ankle. So whatever the venous hypertension changes which happen in the subcutaneous area, they become very evident. One, and second, if you measure the pressure, venous pressure, it is maximum around ankle joint. Okay. So because of these two reasons, it is more common. Typically, what is the area around the ankle means?
No, Gaito's areas.
What is it? Is it a name of a person?
No, sir.
What is it?
Anybody can answer. Anybody can open up an answer, please.
What is the shape of that? Any person you have seen wearing something there which resembles the discoloration in varicose veins in that particular area? It will be like gum shoes, no? What you people nowadays you see. Previously, the one who used to go for wars, no, they used to wear shoes, which used to cover the ankle, so that whenever there is a sword injury, that will prevent the injury to the ankle, because the enemies used to target the limb so that the person will not run away. Okay, that is the area.
Okay, sir.
And one more point in the dilated veins in the lower limbs, I wish you should add this dilated veins. You should describe whether the patient says, are they limited to the leg Are they involving whole of the lower limb? You should
Okay.
ask. One. Second, you should ask your, okay, history you are going to present. Next slide. Okay. Anything?
No, sir. No, sir.
Yes, sir. Yes. So, other than the site of enlarged veins, you should ask whether this person has getting increased swelling or increased size of the limb, maybe towards the evening, and which comes down next day morning. If that
Okay,
history is
sir.
there, if that history is there in a case of varicose veins, what will be your suspicion? Don't mention DVT. Somebody typed, don't mention DVT.
AV malformation, sir.
No, no. He says, along with the enlarged veins which he has noticed in the lower limbs, he says, gradually by evening, the size of the limb will be swollen, but by next day morning, there will be decrease in the size little bit. It is not a very gross swollen limb. Relatively, it is an increased size, and next day morning, after lying down and keeping the limb elevated, he feels better. And along with that, he says there is a pain in the limb. You should keep a possibility of phlebitis or a thrombophlebitis. It is one of the complications of varicose veins. So they may have associated, so not like DVT, DVT is a separate entity. The coexistence of DVT and varicose veins, not a common phenomena. DVT will be there in the past, and presently patient may present with varicosity. Together existing, not a very common entity. You got the point? So
Yes,
if
sir.
that history is there, keep it in mind that, yeah, probably there is thrombophlebitis. If that is a history, and if your thinking is like this, what will be examining during examination?
We'll look for the rise in temperature and tenderness.
Maybe the tenderness, accepted, and a palpable vein in a elevated limb. You got the point?
Okay, sir.
So in
Yes,
case
sir.
of varicosity, veins may be palpable in standing position because of the engorged veins, because of the filled veins. But if they are palpable even after elevation, means there is some luminal entity existing even after elevation, that is thrombophlebitis. Okay?
Okay, sir.
Along with tenderness. Okay, fine. And here dull aching pain, since again we have discussed that. Yeah, fine. We have discussed to differentiate arterial. Sir also has mentioned few points: arterial, venous, and neurological pains. Okay. Fine. Next. Okay. Can you mention why you have asked so many negative points here?
Breathlessness, cough.
Yeah.
Sir, the edema of leg
Okay.
to see if there is any complication of the varicose veins, fever to rule out thrombophlebitis, abdominal distension, pain, and chronic constipation to rule out the cause, secondary cause, breathlessness, cough, hemoptysis to rule out pulmonary embolism as a complication of DVT, trauma, mobilization of the limb to rule out any risk factor, and non-healing bone in the lower limb to rule out any previous wounds, and previous surgery to rule out the recurrence, and long-term hospitalization again to rule out the risk factor for varicose veins.
Yeah, that somebody has typed no non-healing wound in the lower limb. So if it is there, he would have presented no. So there is no need to highlight that yes, there is no non-healing. If it is there, you would have presented that case as a chief complaint and history of present illness. Okay. What is the idea of mentioning long-term hospitalization?
So if previously any surgery, he underwent any surgery which can lead to post-operative deep vein thrombosis.
If a person is developing varicosity following DVT, so what is that likely varicosity he will be developing?
Secondary varicosities, those will be fixed varicosities.
No. That is along with the obstruction. The varicose veins following the event of DVT, following the event. So what is the type of varicosity usually they develop? Do they develop varicosity involving whole of the lower limb or part of the lower limb?
A part of the lower limb, sir.
Which part of the lower limb?
The PGs can answer if they are there. Kishan, any PGs?
DVT commonly occurs in soleal vein, sir.
Okay.
So
Kishan, sir, with your permission, can I just share a slide with one
Yes,
drawing?
sir.
Please, sir.
Yes, sir, please.
Kishan?
Sir, please, sir.
Yes, sir. Yes, sir.
Kishan, no PGs today?
Sir, no, sir. Like these are good. They will answer, sir. You ask them.
No,
Syeda
no
will answer.
problem.
She's bit,
No,
she's
no,
a bit
no
scared. I
problem.
don't know.
No problem.
Sir, stop sharing, Syeda, please. Sir will, yeah.
yes.
Yeah.
If this is the deep system, is it visible to all of you?
Yes, sir.
This I'm explaining, I was asking, following DVT event, what is a varicosity usually person develops? In fact, this has become very common nowadays because the incidence of DVT has increased, both in males and females. So this event usually happens after many years of DVT. And once the person develops DVT, this is the deeper system where there is a thrombus. These are the communicators between the deep system and the superficial system. During the process of recanalization of DVT, this treatment, after treatment, this is during recanalization, what happens? There are veins, there are walls between the junction of a deep system and the communicating veins, or the perforators between the superficial and deep. And these perforating veins are with this direction, the walls are in this direction, because blood has to go in the unidirectional way. So during recanalization, what happens? These are the walls which are there, junction of perforators and the deeper system, which gets destroyed. So they go for incompetence. So following a DVT, and in most of the DVT cases which have been treated with medical treatment, there won't be complete recanalization of the deep system. It is always the most often it is a partial recanalization. So during the process of recanalization, these walls gets destroyed and resulting in incompetence of the perforators. So if it is asked what is a varicosity usually person develops following the DVT, it's a isolated incompetent perforators. In other way around, if we examine a case where a person has come to you with isolated the leg incompetent perforators with a long system being normal, rule out DVT in the past. They may not have given the history, but instantly you should find out, and most often they will have the history of having had DVT in the past. Maybe symptomatic or symptomatic, treated, untreated. Because isolated perforator incompetence, the commonest cause is the past DVT in the limbs. You understood? Yeah, Kishan, you can give our slide now. Kishan?
Yes, sir. Yes, sir. She's sharing.
Yeah.
Syeda?
Can you see, sir?
Yeah, it's loading. Yeah, yes, we can see.
Okay, yeah. Yeah, continue, Saniya.
Should I go to the next?
If a patient has got a past history of DVT, I will insist on you that you should know whether the patient is on treatment for DVT now also. What may be my thinking? What will be the treatment he must be getting for DVT?
Low molecular weight heparin, sir.
Invariably, if you are talking about varicosity, it is a chronic DVT. So for chronic DVT, what treatment will be giving? Oral anticoagulants.
Oh.
Okay, oral anticoagulants, not low molecular weight heparin to begin with. Okay, not aspirin, anticoagulants, oral anticoagulants. Okay, so that history you should know, because varicose veins are more prone for bleeding. So if the person is on anticoagulants with varicosity and if it bleeds, he will have a torrential bleeding. So you need to know that. Okay, continue.
I'll go to the next slide, sir.
Yeah, you said the last 3 years and symptoms are 3 years, and the last 3 years he is using compression stockings. But in spite of that, he has developed pain and he has developed discoloration 6 months. So what is the inference you are drawing?
That it is a chronic state.
Agreed. But what is the inference? He is continuously using the stockings. But in spite of that, he has developed his further problems in the form of getting pain, getting discoloration. So probably stockings have not helped him much. One. Second, probably he may be using the compression stockings may not be the proper way he is using. Second. Third, do you know what are the varicosity which will respond nicely for stocking treatment or a conservative treatment?
Varicosity is with the DVT, sir.
In the sense,
and,
perforator incompetence. Perforator incompetence. They respond well. But if there is a saphenofemoral incompetence, they are less likely to respond to compression stockings. So by mentioning this history, which you have written now, you are drawing a conclusion that probably this gentleman has got a saphenofemoral incompetence, priority wise. Second, probably he is not using them nicely, properly. Okay, continue.
The proper stockings was not the classical varicose vein stockings was something like which is available in the market. They would have used, and they would have used it irregularly, sir, not constantly. The now and then, once the pain subsides, they don't use. That was the reason, I think.
Yeah, continue. Saniya. Yeah, this is anything in the habits you want to highlight because the patient is male?
Yes, sir. The patient has no habits of smoking. Smoking also predisposes to varicose veins, and also alcoholism can lead to.
How smoking predisposes to varicosity? Kishan, shall I, one more slide, shall I?
Yes, sir. Yes, sir. I'll stop sharing. Yeah.
Please, it will not disturb you, no?
No, this is better, sir. In between you draw and show us, it will be better. We'll remember it better, sir.
Okay. Smoking, what I was talking, if you see the varicose vein, that is the venous system in the limbs, for example, this is a long saphenous system and there are walls. Each wall has got an annulus like this. If you see the inside of it, then it will have a flaps. The circular structure of this, the site of the wall is nothing but the collagen. Nothing but the collagen. As you know, this smoking interferes with collagen synthesis. That's what we say even in inguinal hernias. So if you are really the person is a smoker, this is where it happens. It interferes with the collagen synthesis, makes the walls incompetent. So it is not just dilatation. So this itself will not be an effective closure. So this is the reason why the people with smoking develops are more prone for developing varicosity. Please continue. Okay, next slide.
Can you see, sir?
Yeah, sure. Continue. Anything important in this? No,
Oh, yeah.
anything
Yes,
important?
sir.
You jumped. Okay.
Does varicose vein run in families?
Yes, sir.
Yes, sir means, and the next question. Yes. Next, what? Why? What are the conditions that occurs familially?
Familial varicose veins occur. The gene which is involved is FOXG2 gene mutation. There can be some, it can also be associated with some collagen and connective tissue disorders.
FOXC2. Okay.
FOXC2.
Yes. Any other syndromes which can lead out to? You can see the chat.
Parkes-Weber syndrome, sir.
Fine.
It usually presents with varicose veins and multiple AV fistulas with chronic venous hypertension.
Gigantism of the limbs, hemangiomas, and AV malformation. Okay.
Okay.
All right. Yes,
Right.
sir. Please.
Fine. Yeah, continue. Okay, we have discussed this now. So on history, you think it is probably a case of varicose veins. Okay. Why not it's a case of AV fistula, artery venous fistula, on history wise? Okay, fistulas are more common in children, one. And second, AV fistulas will have a local gigantism in the sense, that will be one of their complaint, that there is a disparity in the size of the limb, more so the toes and the foot. So if it is a AV fistula, so that particular history in a young patient, and it will be associated with a local gigantism, and that history will be there. So in this, it is just for discussion what I'm bringing this point for discussion. Okay. So it is unlikely to be a AV fistula. Okay, continue. Examination.
Physical examination. Informed consent was taken from the patient. Patient was examined in a well-lit room. Height 177 centimeter, weight 90 kg, BMI 31 kg per meter square. Vitals, pulse 75 beats per minute, regular rhythm, good volume, normal character. BP 122 by 80 millimeters of mercury, measured in left arm in sitting position. Respiratory rate 15 breaths per minute, temperature 37.5 degrees Celsius. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, pedal edema. Local examination. Patient was examined in standing position with both limbs exposed from umbilicus below. Inspection. Attitude of the limb is normal. Localized multiple dilated veins present on his right lower limb. The course was the lower 1/3 of medial aspect of thigh, medial aspect of leg just below the knee and in front of the medial malleolus. Blackish disc, pigmentation of skin over right ankle. The skin is not stretched and shiny, no eczema. No ulcer, scar, scratch marks, loss of hair. Safina varix is not present. The other limb appears to be normal. Palpation. No local rise of temperature over the dilated veins. No tenderness. No thickening of veins. No thickening of skin. No pitting edema. A specific test. Brody-Trendelenburg test. Test 1. There was a rapid filling of blood above downwards, which indicates saphenofemoral incompetence is present. Test 2, there was gradual filling of blood from below upwards, which indicated perforator incompetence is present. Tourniquet's test indicated incompetence of above knee, below knee, and lower leg perforators. Modified Perthes test, the varicosities shrink. Schwartz test, impulse felt at the saphenous opening, implies valves along GSV are intent and involves single continuous column of blood. Pratt's test, blowout seen at above knee, below knee, and lower leg perforator sites. Morrissey's cough impulse, expansile cough impulse felt at the saphenofemoral junction. Fagan's method, depressions felt at above knee, below knee, and lower leg perforator sites. Percussion squad sign is positive. Auscultation, no murmurs heard. No palpable regional lymph nodes. Left lower limb is normal. All arterial pulsations felt. Systemic examination. Cardiovascular system, S1, S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds heard. Central nervous system, no focal neurological deficits. Per abdomen, no distension, no organomegaly, no palpable mass, bowel sounds heard. Provisional diagnosis. Varicose veins in the right lower limb.
We'll come back to this. Can you put the clinical photograph? You have photographs?
Yes, sir, yes.
Oh, this is the one?
Yes, sir.
Okay, fine. Okay.
More below the knee, isn't it? Not above the knee.
Yes, sir.
Is there anything above the knee?
Her description she has, but there are no photographs.
There's no photographs. No problem. No problem. First of all, you did a very good clinical examination. You did a very good clinical presentation. For an undergraduate, you are through. As far as this level is concerned, I think myself and Sir will say you are through, because a good clinical presentation has taken you off the way. Then the discussion and everything is all given in the book. And you have mentioned about Pratt's test. I don't think, Sir, are you doing it now, sir? Even
no,
short,
yeah.
even weekends, no problem. You have done it. We appreciate your thing. You are done all the tests. But Pratt's test is not done nowadays. Short test is done. So we'll come to that later. First of all, we appreciate your very good presentation. Very good for an undergraduate. You have done an excellent clinical presentation. Now we have to ask you, how did you do each by each? You have seen the photograph. Okay. Now come to your clinical examination. 1. Informed consent. Yes, right. If it's a female patient or a male, any patient in the presence of an attender, one thing you usually add. Okay, nothing wrong in it. They come to strip as below the umbilicus, you have to strip and see. Yes. Come to your inspection finding. Yes. Seen on his right lower limb, 1/3 medial aspect of the thigh. Thigh also is seen, isn't it?
Yes,
so
sir.
which system? Now, my basic question is, define varicose vein.
Varicose veins are dilated and tortuous veins, which are greater than 3 millimeters in diameter.
Very good. Dilated, tortuous, elongated, greater than 3 millimeters, subcutaneous veins.
Subcutaneous.
5 points to say. Okay, subcutaneous, dilated, tortuous, elongated, more than. The medial aspect you said and front of the knee. Is this got any importance, medial aspect and the lateral aspect?
Medial aspect, we suspect for great saphenous vein involvement, and lateral aspect, short saphenous vein involvement.
Right. The black is you change it to hyperpigmentation seen.
Okay, sir.
Skin is not stretched and shiny. Sir, please, sir, take over. Just one.
Yes, sir. Yes, sir.
Srinivasan, sir. Sorry to
Yes, sir.
interrupt. Srinivasan, sir.
Yes.
In the definition, should we mention permanently dilated?
Permanent, I don't think so.
Okay, sir.
The actual classical definition is this thing: subcutaneous veins, dilated, tortuous, elongated, and more than 3 millimeters is called varicosity veins. So should we say permanent?
Yeah, it is not required, Kishan. These three, but elongated, some people may accept, may not accept.
Some may.
But yeah, because it is obvious that tortuous veins will be elongated veins only. Only the length will be more if it is tortuous like this. So automatically it is understood. But permanent, Kishan, I don't know. It's
did you read it somewhere, Kishan? No problem. You can. Kishan?
I'm just asking for the benefit of others, sir.
No, I don't think so. You should mention. The other points should be mentioned. She had explained it very good.
Saniya, what is like more than 3 millimeters? What about less than 3 millimeters? They are normal veins, or if they are easily seen?
Veins.
Reticular veins. Yeah, less than 1 millimeter, it is called the telangiectasia or thready veins. 1 to 3 is reticular veins, and more than 3 is varicosity. Okay. And you said that depending on the site, you can conclude whether it is a long saphenous system or the short saphenous system. Okay.
Yes.
You have mentioned the skin is not stretched and shiny and no eczema. Like, how did you come to know that on inspection this is not the case? Like, it is not stretched?
Um, it was not shiny, sir.
Okay. What does it indicate?
There is no complication of varicose veins
In the sense?
like lipodermatosclerosis.
Okay. It is not a lipodermatosclerosis. In that case, there will be a lot of fibrosis and it will
Yes,
not
sir.
be shiny there. It will not be
Yes.
shiny. It is a thick skin, white skin. It will be very tough skin because of the fibrosis.
Yes.
Okay. Here, the shininess, it indicates there is no underlying inflammation going on.
Okay, sir.
Okay. So there is no inflammation like phlebitis. There is no inflammation.
Okay,
Okay.
sir.
And loss of hair, I don't know whether really you should highlight. Yeah, because you wanted to rule out the arterial disease.
Arterial disc.
Yes,
That's
sir.
why scratch marks. Scratch marks. Okay, sometimes a patient long-standing chronic venous, you will have some itching.
Yes.
So you mentioned no ulcer, no scar, no scratch marks. Okay, nothing wrong, but okay, good,
And
good.
on inspection, one more point you should highlight, like what we say in inguinal hernia. After describing the details of the lower limb in standing position, you should highlight
Okay.
that patient inspected on standing position. And
Okay.
on laying down after elevating the limb, there is a collapse of the
Vein
venous system.
collapse.
You should
Yes.
highlight this point. Okay,
Yes.
that you have missed. That indicates two things. One, there is no obstruction there, means there is no phlebitis. And second, probably it's a varicose veins. Means on inspection, you are confirming. On
Okay,
inspection,
sir.
you are confirming that it is engorged veins. Second, you are ruling out one of the complications of varicosity by just
Okay.
inspecting the limb. So this has to be mentioned in the inspection itself. After lying down and making the limb elevated, the veins collapse. Okay,
Okay,
they are
sir.
not obvious. Okay, palpation. Next slide. Yeah, you come to the test, no? You mentioned all those, like
Yes.
sir said, no? You mentioned so nicely. Can you describe, fast each one of them in 1 or 2
Okay, sir.
minutes?
Brody-Trendelenburg test, the patient is made to lie supine and the leg is elevated to empty the veins, and a tourniquet is tied just below the saphenofemoral junction. The patient is made to stand and the tourniquet is released. So there is gradual filling of blood from above downwards that indicates saphenofemoral incompetence is present. In test 2, everything, the same procedure is carried on, and the tourniquet, in the standing position, the tourniquet is not released. So there will be gradual filling of blood from below upwards. That indicates perforator incompetence is present.
Yeah,
In
stop 1 second. This Trendelenburg test. Now, you said you will tie the tourniquet just below the saphenofemoral. I request all the candidates, whoever is listening, because there are no case physical examination now, which may not be there for another 6 months. Please understand what I am talking now, because you have to imagine a little bit here. Okay. Now, Saniya, you tell me, you said you are going to tie a tourniquet at saphenofemoral junction. Okay.
Yes, sir.
Where will you place the knot of the tourniquet?
Towards the medial side, sir.
That's what the people do. See, Nidhi has answered laterally. Okay, see, these are all important. This we demonstrate whenever we take clinics, whenever physically everybody is present around. That is the difference between physical examination and online, so-called sophisticated online with all hi-fi, the technology items. That is a difference. Okay, if you tie the knot medially, that comes in the way of visualization and you will have a difficulty in releasing the knot. Okay, so the knot, and you cannot have a complete compression of saphenofemoral junction if you tie the knot medially. You cannot have. You cannot have. So
Okay,
the whole of the loop of the tourniquet should be over the medial and anterior side of the thigh completely. If you do that completely, automatically knot has to be on the lateral side, and it will have a good complete compression. And second, it will be easy to release the knot.
visual.
Okay, that is the reason. One. Second, in both the tests, you mentioned gradual refilling of the vein, which is wrong. In the
In
first
first,
test,
it's rapid filling.
rapid. See how terminologies makes difference?
Rapidly filling from above down,
From
downwards.
downwards.
Below upwards. Okay, these are the terms. Sir is telling very clear terminology.
Exactly. Gradually should be for the part 2. It is not
Yes,
test
sir.
2. It is part 2. Part 2.
Okay.
Both are Trendelenburg test. It is part 1, part 2. And in all the cases of long saphenous system varicosity, you are supposed to do both the parts.
Okay,
Both
sir.
the parts. It is like always I give this with the inguinal hernia examination for the undergraduates. Your ring occlusion test will be incomplete unless you examine again after taking out and making him to cough again, because it is a witnessing of the cough impulse, which is the positive test. Most of you, what you do, just occlude and comment whether it is direct or indirect, which is wrong. It is half of the test. So here, the Trendelenburg test, they are for part 1 and part 2. Okay. So you have described and you have given the reasons. Okay, next.
Tourniquets test. Here
Yeah,
the patient is
how many tourniquets you will be putting?
4 tourniquets, sir.
Okay, where all?
One just below the saphenofemoral junction. Second
What
at
do
the
you do
mid
before
thigh.
putting the tourniquet? What do you do?
Make the patient lie supine and elevate the leg and empty the veins.
Okay, fine.
First tourniquet just below the saphenofemoral junction, second at the mid thigh, third just below the knee, fourth just above the ankle.
Okay, what is the idea of doing this?
Between the tourniquets, we can see dilated veins.
Okay.
So that will indicate incompetence of the perforators.
In the same position of the limb? Position of the limb will be same while tying what you had the position?
No, sir.
Huh?
The limb will be resting on the patient will be made to stand, sir.
That's what you should tell.
Yes.
After tying the tourniquet, make the patient to stand. Make the patient to stand. See, the principle of this test, please remember these words. Whole of the lower limb is divided into segments by tying these tourniquets at those particular points which you have mentioned.
Yes.
Each of these segments which you have made the limb into segments, each segment will have a named perforator. Named perforator.
Yes.
Okay, named. There are many unnamed perforators. So each segment of the limb will have a named perforator, which you are going to identify when the patient stands. So that is a principle of this multiple tourniquet test. And tying the tourniquet, it is the same which I have described for the Trendelenburg test. Okay. Yeah, shorts test. What is the precaution you take when you do shorts test? What is the position of the limb?
The patient is made to stand, sir.
Okay.
The distal most varicosities is located, and we tap on the varicosities. So an impulse is felt at the saphenofemoral junction.
Oh, you mean you will be tapping over the ankle and you will be appreciating at saphenofemoral junction?
Wherever the distal most varicose vein is
so
present.
you tell no where exactly. That is the fallacy of this
in the
shorts
lower
test.
leg. Lower leg, sir.
Where will you keep the what is this tapping? It's a tapping hand. What is the left hand called? If you are tapping with the right hand, what is that left hand called?
Palpatory hand.
Appreciating hand.
Appreciate.
Yeah, it appreciates the impulse. This creates the impulse. Okay. So where do you keep this appreciating hand?
At the saphenofemoral junction.
No. See, if there is a lot of varicosity, if the tortuosity is more, this test may not be positive by the way what you described. You cannot keep the hand at saphenofemoral junction and tap here and expect that you will be appreciated because it's tortuous.
Yes.
To say that shorts test is positive, you are written here single continuous column of blood. If it is a tortuous vein, it cannot be a single column of blood. It is a broken columns.
Yes.
If it is a broken columns, the impulse will not be appreciated. So you have to take a straight segment of the vein. It is not necessary that you should be a longer one. Straight segment of the vein. There it indicates it is a single column of blood. One. Second, it indicates there are no in between interfering valves.
Oh, yes, sir.
Because of the dilatation, they go away from the flow. They go away. So it forms a single column of blood. So there are no intervening walls and a single column of blood. So you have to take a straight segment of the vein. That is why the fallacy is, it indicates only that particular area where you are doing the percussing and appreciating, only that segment is having an incompetent wall. That's what the inference is.
Okay, sir.
Okay, fine. Like Prats sir said, yeah, it is not being done, we will not. What is this cough impulse test?
The patient is made to lie supine and the leg is elevated, and then the leg is rested on the bed, and the patient is asked to cough forcibly. So an expansile cough impulse is felt at the saphenofemoral junction.
This test is done by only the clinician or done by someone else in a case of varicose veins?
Physician, sir.
Is this test done by a clinician, examining clinician, or is the test also done by someone else in a case of varicose veins?
Someone else, sir, because
Who?
the clinician might be
Who is that
observing
someone else? Who is that someone else?
patients.
No, he cannot examine. No, patient cannot examine. In other words, this is the test which is taken into consideration when you send the patient to a radiologist for doing a Doppler
Yes.
study. He will mention in the report, you must have read the report, no? Reflux
Yes.
of blood from the deep system into the superficial system through saphenofemoral junction. This is the reason.
Okay.
Is the reason. Okay. You, as a clinician, you are feeling the cough impulse there. As a radiologist, he is appreciating on the screen. Okay.
Okay, sir.
Okay. What is the Fagans?
In Fagan's method, first the patient is made to stand and all the dilated veins are marked using a marker. The patient is then asked to lie supine and then the marked sites are palpated. So depressions are felt at the incompetent perforator sites.
Where are those depressions?
Here in this case, it is above knee, below knee, and the lower leg perforator site.
No. Sarah is asking, you feel the depression, isn't it?
Yes,
the
sir.
depression is defect in where?
The deep fascia, sir.
Yeah,
There will be stretching of the deep fascia because of incompetent perforators.
Normally, they are not there because normally perforators are there, no?
The perforators are competent, sir.
No, but those facial defects are there or not normally? Then how can the perforator go into the deep system from the perforator, superficial system?
Fascia is present, sir, but
it is
I don't
there,
know if
but it is not felt only when there is a perforator incompetence, huge perforator incompetence, then there is a blowout. There is a blowout. It is called typically blowout. You appreciate the Figgins test very well. Okay, in small. Yes, sir, please. Sir.
These perforators, they get dilated once they become incompetent. So during the process of dilatation, they cause a stretching of the fascia. So once that stretching of the fascia is there, the defect becomes a bigger ones, which clinically they are appreciated. And this is the test name given. You got the point? Okay, next slide. Next slide. What are the types of perforators?
It can be one is direct perforators, another is indirect perforators.
Okay, very good. Very good. Well, you know what are the direct and indirect?
Yes, sir. Like I know what's the definition. I don't know.
Yeah, you tell the definition. You're good.
Direct perforators, they connect superficial veins to the deep veins directly, and indirect perforators, they connect the superficial and deep veins through the muscles.
They pierce the deep fascia, form a plexus, then take another route and connect the deep veins. Okay.
Okay.
That is, sir. What is the name of the ankle perforators which you said, which is leading on to the edema and hyperpigmentation? Name of the, you have written Dodd, Cockett, Boyd. Very good. Any other thing?
Yes, sir.
Yeah.
Kastner,
May and Kastner.
Way and Kastner.
Yes.
Okay, yeah. Now we'll go to the diagnosis.
Provisional diet.
You look for auscultation. Auscultation, what do you actually look for in a varicose vein?
Sir, we look for machinery murmur, which is seen in AV malformation, and bruits also can be heard in some cases.
Continuous murmur, brewing in AV malformation. In that
Yes.
case, is it compressible or reducible? AV fistula is compressible or reducible? Is there a
It is
difference
reducible,
between
sir.
continuous AV fistula is reducible or compressible?
Reducible, sir.
Okay, proceed.
Provisional diagnosis: varicose veins in the right lower limb of primary etiology involving great saphenous vein with saphenofemoral incompetence and above knee, below knee, and lower leg perforator incompetence without any complications. CEAP classification is C4A, EP, ASP, PR.
Yeah, you
Okay.
describe, no, just for others' sake. Otherwise,
Yeah.
it looks Greek and Latin, all this C4. Huh? Yeah.
Yes, sir. C is the clinical classification. C0 is asymptomatic.
No,
C1,
you just tell what
No,
is
see,
4
what
now.
is C4A?
C4A is a presentation in which skin is involved. There is pigmentation in this case. So it is C4A.
What is
Fine.
C4B?
C4B is involvement with lipodermatosclerosis.
Is there any C4C?
No, sir.
You do not know, no problem. It has been included in the 2020 classification. C4 is called the corona phlegmectasia. Phlegmectasia. Yes, Mohammed Asarjan has answered.
Yes.
Very good, very good. Corona phlegmectasia. Yes. There are some more changes also have come in 2020. Have you heard?
E is
E
primary.
is
P is
etiology.
primary.
EP.
P is primary, S is secondary etiology. A is anatomical, which is superficial and perforator incompetence. P is pathology, which is mainly reflux here.
Okay. What are the other things in pathophysiology?
Obstruction, sir.
Okay.
And it can either be a reflux and obstruction together.
Okay. In etiological?
Etiological, it can be congenital, primary, and secondary.
And in anatomical?
Superficial, superficial veins, deep veins, and perforator incompetence.
And perforators. Sometimes they include where they have not been named. In anatomical, unnamed vessels.
Okay.
Unnamed vessels. Okay. So this is what the classification you mean. Okay. Now, how to proceed now?
Investigation: duplex ultrasonography, other tests, complete blood count, random blood sugar, renal function test, liver function test, ECG, abdominal ultrasonography. Treatment:
No. Go to the first slide, ma. Yes, duplex. Duplex or Doppler? The standard questions again. What is Doppler? What is duplex?
Duplex is a combined study of B-mode ultrasonography and Doppler study. And Doppler study is done using a Doppler probe. In duplex, we first find out the anatomy.
What will be the classical finding you get in the saphenofemoral incompetence in an ultrasound, duplex ultrasound?
In duplex ultrasound, it has color flow map.
Yes.
So normally the vein is compressed. At that time, it shows blue color. And when the vein is relaxed, there is no backflow normally. But in varicose veins, when the valves are incompetent, there is backflow of blood. So it shows red color in the color flow map.
Okay.
What is that sign called? Somebody had written. If there is incompetence at saphenofemoral junction and duplex, what is that sign called?
He has written whoosh, whoosh sign, sir.
Whoosh sign. That
Mickey
is
Mouse sign.
Mickey Mouse sign.
Mickey Mouse sign.
Yeah, yes.
Mickey Mouse sign. It mimics the nose and 2 ears of Mickey Mouse. All 3 structures, that is femoral artery, femoral vein, and and the saphenous vein at junction.
Yes.
Okay.
Okay. These are all you're doing for anesthetic purposes, for surgical purposes. Right. What ultrasonogram of what?
Abdomen and pelvis, sir.
To rule out?
Any obstruction in the abdomen. To rule out any abdominal tumors.
You can say to rule out any secondary causes which is not detected clinically.
Okay.
Can you highlight on some of the secondary causes of the
secondary causes? It can be due to obstruction or high venous pressure, or due to deep vein thrombosis. Due to obstruction, physiological reason is pregnancy. And other reasons are ovarian cysts, pelvic tumors, abdominal lymphadenopathy, pelvic tumors.
Okay.
One more to add to this, the importance of USG, what all things you have mentioned. Yes, right. That is to know the secondary causes, secondary varicosity. Depending on that, in that etiological factor, following DVT or following obstruction, they have been classified. You must be knowing from above downwards, starting from vena cava, it is labeled from vena cava, iliac veins, external, internal, then femoral, superficial femoral, peroneal, like that, till the ankle veins. So they have been named from 1 to almost 10, 15, okay, depending on the site of obstruction. For that reason, it is. How this varicosity will be different from primary varicosity, if it is a secondary varicosity?
The varicosities will be fixed, sir.
Fixed varicosity. Where else you get any other condition other than lower limb, where you get a fixed entity like this? In some conditions other than lower limbs?
I don't know, sir.
Any other venous structure where it will be something like fixed only, like this only, for some other reason?
Esophageal varices, sir.
No, they cannot be fixed. No, fixed means what? Even after elevation, it should be felt.
They don't get.
So can you elevate the stomach, esophagus, and palpate? So it should be accessible organ.
Yes, it is.
So
varicocele.
Varicocele. So in which condition it will be a fixed varicocele? Which side? Left side more common, right side more common?
Left side.
Why left side?
Very good. You're answering. Keep up now. Tell why left side. It's coming.
Where does it drain? Where does it drain? Left testicular vein.
Left.
See,
testicular vein drains to left renal vein. So in a case of renal cell carcinoma with a tumor thrombus extending into the renal vein, if the renal vein is causing obstruction to the testicular vein which drains to it, the person will have a fixed varicosity. Okay, fixed varicosity.
It is common in tall, thin people. Okay, and they say left side testis hangs at a lower level, and it has taken a longer course, drains into the left renal vein, along with the left adrenal vein, where the catecholamines is released. That is some of the reason. And left side, as Sir said, left side renal cell carcinoma is very common, and left sided colon is loaded compared to the right side. So left sided colon is loaded, it can compress. These are some of the reasons why left sided varicocele is more common. Okay.
Okay, sir.
What is the feeling you get when you touch that? As Sir went into varicocele, I'm asking you.
Not fixed varicosity, sir is asking. It is varicocele is asking in general, varicocele.
Somebody has bag of worms they have written. Okay.
Yeah, Saniya, coming to this duplex, what all information you will get in varicose veins with this investigation?
We can first tell about the anatomy of the deep veins. If there is deep vein thrombosis, the veins are not compressible. Second, the venous valves, if they are competent or incompetent. If they are incompetent, a reflux of blood will be seen. A whoosh sign more than 0.5 seconds will be seen. And then in the color flow map, red and blue color will be seen.
Anything
and
else?
The site of reflux can be located.
Okay.
The site of perforator incompetence can be located.
What are the other information you'll be getting? Okay. On this Doppler and duplex together, they give the report for imaging of varicose veins.
Hemodynamic mapping can also be done, sir.
Okay. Anything? Yeah, this whole lower limb is divided into zones, 6 zones. Okay. Radiologists give the report in the form of zones. So these, depending on the zones, they comment on the incompetent perforators. Okay. So that is the one which they, other than those 2 points which you have mentioned, this is the third point. Fourth point, you will come to know, is there any thrombus in the superficial venous system? You know what is the difference between phlebothrombosis and thrombophlebitis?
Phlebothrombosis. Thrombophlebitis is inflammation of the vein, sir. Okay. Phlebothrombosis is thrombus in the vein.
Okay, one. And second, phlebothrombosis can be limited to part of the vein. Thrombophlebitis, usually it is an extensive entity. Whole length of the vein may be involved. Okay, so that also you can find out on Doppler. Duplex. Yeah, duplex scan. Okay, so these are the few things which you will have the information. Okay, next. So what will you do for this gentleman?
Treatment, saphenofemoral flush ligation, stripping of the great saphenous vein up to the upper calf, and ligation of above knee, below knee, and lower leg perforators.
Okay. What is that one condition you should rule out before you venture upon doing surgery on these limbs?
Deep vein thrombosis.
Deep vein thrombosis you should rule out. So that is an absolute contraindication. Why it makes absolute contraindication?
Because even the deep veins are damaged, sir. If even the superficial veins are cut, then there will be no blood flow back to the heart. No
venous drainage. You are not bothered about heart. We are bothered about the limb.
Yes, sir.
There is no venous drainage for the limb. Heart will be getting the blood from other areas.
Yes, sir. Yes.
Okay.
Venous gangrene. Typically, some is good.
Okay, fine. Okay, can you substantiate your Hughes very long surgical procedure which you have mentioned here?
Trendelenburg surgery.
No, substantiate. Why do you want all of this? Substantiate for your case.
Sir, saphenofemoral flush ligation.
Because he has incompetence.
Incompetence.
Okay, just tell us what is meaning of that and what is being done.
In saphenofemoral flush ligation, so the great saphenous vein is being ligated close to the femoral vein along with its tributaries, superficial circumflex iliac vein, superficial epigastric, and superficial external pudendal vein. Also, accessory saphenous vein and deep pudendal vein are ligated.
Okay. We'll go one by one so that others also will be able to understand, because you are not able to see nowadays again the same.
Yes, sir.
Because of these problems.
Sir, do you have any videos of same, please?
I don't know, Kishan. If you would have told me earlier, I would have shown good photographs, good videos, and my videos.
Yes, sir.
And there are few sonography, the questions also.
Yes,
I was busy today. That's why I could not prepare. I had like for undergraduates where they can understand so nicely.
Yes, sir.
If Nishant is there, he will tell you what we do when we operate. We especially for the PGs, what is anatomy, what exactly you should be doing, how long you should dissect that the long saphenous vein from saphenofemoral junction, and what is the idea of doing that. Kishan, next time I think we will have a discussion before and we'll prepare so that the students will be benefited.
yes, sir.
Okay.
What is
Last
the
time we
reason
got a lot
for
of
you?
reviews, sir, about that
Yeah.
video. That's why I asked in particular, sir.
Yeah. It's better if they can see video and they will understand. I'll just tell a few things in their own way. They will understand because they know the anatomy. Saniya, what you have described is nice, but you said flush ligation along with those three tributaries. It is not along with those three tributaries. You need to ligate those three tributaries before you do a flush ligation.
Yes, sir.
Okay, so it has to be proximal to those tributaries. If you do a ligation distal to those tributaries without ligating them, then they may have a recurrence of those three tributaries. I label them, Nishant is there, if he is hearing, he may laugh. I label them as three namas. You are able to see my fingers there on the screen? Three namas, like. So one is middle is superficial inferior epigastric vein. The medial one is the external pudendal, lateral will be the circumflex iliac. So those are the three we have to identify and ligate. What is the meaning of that flush ligation?
Ligating close to the femoral vein, sir.
In flush with the femoral vein. That is a meaning. That flush is for the femoral vein, not for the saphenous vein. Okay, in flush with the femoral vein. That is the idea of doing that. Again, that is to prevent.
Development of saphina varix, sir. Dilatation of the great saphenous vein near the saphenofemoral junction.
Yeah, segment development in a post-surgery. If a person develops there, then that we call it as a saphina varix. It is nothing but a varices. What we talk about esophageal varices. Like that, it is the varix at the saphenofemoral junction because of the segment of saphenous vein which is left with a femoral vein. Okay. What is when you do surgeries? What is that important structure which will cause damage at saphenofemoral junction? Anatomically, if you don't take care, what is that structure which comes or which will give some clue that yes, it is a saphenofemoral junction?
Cribriform fascia.
Yeah, exactly, cribriform fascia. Okay, what is
opening?
What is that? What is that opening where the saphenous vein pierces? Like an arcuate line over which the long saphenous vein hooks and then dips into that fascia to join into the femoral vein. So that is one of the identification point to say that yes, you are in flush with a femoral vein. You are in flush with a femoral vein. One. Second, you know what is the distance of the mobilization of the long saphenous vein from saphenofemoral junction before you pass a strip, the stripper? Okay, around 10 to 15 centimeter of long saphenous vein in that tunnel from the saphenofemoral junction distally down, we need to mobilize. The reason why you need to mobilize 10 to 15 centimeter, there will be tributaries, thigh tributaries, named tributaries, which are joining the long saphenous vein. Okay, that is
Yes,
the
sir.
posteromedial and anterolateral tributaries, the main two important tributaries. So
Yes,
these
sir.
two tributaries needs to be ligated, otherwise they can have a recurrence. Okay, so you need to mobilize proximal 10 to 15 centimeter of long saphenous vein from saphenofemoral junction, find out these tributaries, tackle them, and then pass the stripper and do a further surgery. And you said stripping is done up to the calf region or up to the lower thigh. Why not lower down?
In the lower leg, the great saphenous vein is in close proximity with the saphenous nerves.
Okay.
So there can be damage to the saphenous nerve.
What happens if you damage the saphenous nerve?
If the saphenous nerve is damaged, the patient can present with loss of sensation over the medial side of the leg.
So is it a big deal? Even in
Sorry,
inguinal hernia, they will have some loss of sensation, no, for some time in the groin. And not only patient complaining, someone else also will complain. There is no sensation there. So, okay. This stripping till the lower leg, lower thigh, it is called a short stripping of the long saphenous system. Short
Okay.
stripping. Okay. Earlier days, we used to strip whole length of the vein. And now, because the veins have become precious, we don't know when the person is going to need those veins for his cardiac problems. So we need to excise or remove only the limited area in the thigh. Okay.
Okay, sir.
And you said ligation of perforators. How are they
Yes.
ligated in the open surgery?
In the open surgery, through Linton's vertical approach, skin incision is given, or small incisions at the site of the incompetence is given.
You are from which college, lady? You are from which college?
BGSGIMS, sir.
Okay.
BGS.
You have read any notes from our institute, or you have spoken to any people from our institute, your seniors?
No, sir.
No. Okay, fine. Good. Very good. Okay, fine. Yeah, this Linton's method earlier they used to do. Nowadays it is not being practiced. It is a very morbid procedure where you will have a very lengthy incision from popliteal fossa till the ankle.
Yes.
And yeah, it is not being. But if you know and if you are able to describe, it is excellent. Okay.
Stab
Ultimately,
avulsion technique or hook fluebectomy. Now they call it a stab avulsion technique, isn't it, sir? Or hook fluebectomy.
yeah, hook.
Hook.
That will come back, sir. Later, because she has written this, we'll finish off this, and later
No.
we'll ask them what are the other options available. Where are they ligated? Where exactly these veins are ligated?
Either they can either be ligate suprafacial or subfacial, sir.
What is ideal? Where they should be ligated ideally?
Subfacial, sir.
It is subfacial ligation only. It is a subfacial ligation. Why you are mentioning suprafacial? There are now people who say that only stripping is enough. There is no need to do the perforator ligation, because once you strip, you are going to disconnect the long saphenous system from the perforators. So the perforator underneath the fascia will get collapsed. So automatically you are going to treat perforators indirectly. So that is why this has come. But ideally, if your plan is this is really to be done subfacial. If you are getting a case where there are only isolated incompetent perforators,
Okay.
then you have to do a subfacial ligation. Okay. This is about the treatment. Any idea what is being done after surgery?
Compression stockings are given, sir, as soon as the surgery is completed, because it prevents from formation of hematoma and bleedings.
Okay. What are the complications you expect?
Complications of what?
Doing this surgery?
Hemorrhage. They can be superficial thrombophlebitis, deep vein thrombosis.
There is no vein, no, to get phlebitis. You are stripped.
Yes, sir.
Okay. So they may develop DVT. And important is there can be injury to the saphenofemoral junction.
Yes, sir.
Femoral junction. There can be avulsion of the junction. That is one of the important and a serious complication on table. Okay, fine. What are the other options available now for varicosity? It is now theoretical aspects. What are the other options? And just tell us what are the different ways of treating varicosity and their indications.
Okay, sir. So the recent advances in the treatment are there is a radio frequency ablation present. So in radio frequency ablation, it is endothermal ablation. In this, a radio frequency catheter is introduced into the main trunk of the vein over a guide wire, and then the catheter is connected to the radio frequency generator. A radio frequency wave is delivered to the vein with a target temperature of 120 degrees Celsius. So the heat generated will cause thermal injury to the veins. So there will be endothelial damage and fibrotic sealing of the lumen of the vein.
Good. What is the major problem of this?
Skin burns, sir. And then there can be
Okay.
pigmentation of skin.
Okay. And you said targeted. This targeted may be a missed target sometimes.
Okay.
That is a deadliest complication. Okay. So it can go somewhere else, maybe sometimes to the deeper areas. One. And second is in the after some time during follow-up, it can get again recanalized, resulting in recurrence. Okay. Same principle is for laser also.
In laser, there are steam bubbles get generated at the tip of the laser, sir, and then the thermal injury occurs. Same thing.
So ultimately, your plan is to damage the endothelial layer so that they get abutted each other. One of the principle is see that whenever you do this procedure, see that there is not much blood in between the two walls. And second, you need to put a compression dressing so that it will be abutting each other and hope that it will get collapsed permanently. Okay.
Yes, sir.
So again, the same, the complications with laser, it can be mistargeted. It can go into the cephalofemoral junction down into the DVT or deeper systems.
Yes.
Okay. And in both the procedures, the recurrence chances compared to the open surgical procedure is very high.
Yes.
Okay. Recanalization chances are very high. Okay. And now what are the other procedures?
Other procedures, we can do sclerotherapy by dividing the vein into shorter segments, sir. So in sclerotherapy, sclerosant solution is injected into the vein, and this destroys the endothelial lining and causes fibrotic occlusion of the vein. So for this to be effective, it should the sclerosant solution should be injected in an empty vein.
Okay. What are the types of sclerotherapy?
Microsclerotherapy, macrosclerotherapy, foam sclerotherapy.
Yeah, describe.
In microsclerotherapy, injection of 0.1 ml of very dilute solution of the sclerosant is used. In foam sclerotherapy, the sclerosant is mixed with air in a ratio of 1:4. Macrosclerotherapy is the limb is elevated and small volume of 0.5 ml of the sclerosant solution is injected.
Okay. What out of three, which is the most effective way of doing sclerotherapy?
Foam sclerotherapy. Sir.
Why? What is the reason?
Because it covers a larger surface area
with a minimum drug dosage.
Yeah.
Okay, because that air, whatever the air fall, the foams which you have generated, it is going to have a more surface area. It will have more contact surface area. And you know what are the types of foam sclerotherapy?
Types? No, sir, I don't know.
Okay, there are two types depending on how much solution and how much air you are putting. Okay. If the solution which you said 1:4, it is 1:5. Okay. If the solution is going to be less than 5%, then it is called a dry foam sclerotherapy.
Okay.
If the percentage of solution is more than 5%, it is going to be a wet foam sclerotherapy. Ideally, we need to have a wet foam sclerotherapy. Dry foam sclerotherapy may not be much effective. Means you need to have a 5% and above. And that will have more, like, even though if you compare with the direct sclerotherapy, that is called liquid sclerotherapy. You are directly injecting the drug into the venous system. That is liquid sclerotherapy. So this is foam sclerotherapy. So if you compare with the liquid sclerotherapy, here the dose drug available is less. In that you classify into two, less than 5%, more than 5%. Okay. You know how it is being done? What is the method?
They take a 23 gauge needle and they introduce it into the vein when the limb is elevated, and then the vein is emptied, and then the volume of drug is injected.
Is it a single puncture or single puncture or multiple?
Single, sir.
Yeah, it's all right. These are given at multiple sites. Okay. So single injection will not obliterate whole length of the vein. Okay. So
Okay.
depending on the communications, you mark them in the standing position and you puncture the vein in standing position itself, because you'll be able to puncture them nicely with the needle and the cannula in a standing distended vein. So
Okay.
you fix them at multiple sites. Then ask the patient to lie down and limb elevated so that the vein gets emptied. Because when you inject these things, the vein should be empty vein without any blood column. So once you inject them, take out the cannula and put a pressure dressing. And these things are injected at multiple places. Multiple places. Okay. If your plan is to do, if I say you treat this particular patient only with sclerotherapy, nothing else. So what is that patient you will be treating? In other words, I am asking you, what is the indication for sclerotherapy?
Reticular veins, telangiectasia.
Sometimes these veins may not require any active treatment. Okay, telangiectasia and reticular veins may not require any treatment. So it is a
Cosmetic.
recurrent,
Yes, sir.
isolated, incompetent perforator becomes the indication for sclerotherapy. If you are talking about varicose veins. Okay. Isolated, recurrent, and perforator incompetence. Because the area is very small. You have got a solitary area of the disease. So you can treat them by giving injection. Okay. So that becomes the indication. Any other way of treating varicose veins?
One question, sir. What are the common sclerosants used? Can you name 1 2 common sclerosants?
The most common one used is sodium tetrahydroxide. Others are sodium morphate. Can you hear me, sir?
Yes, yes. They have written ethanolamine oleate, sodium tetrahydroxide sulfate, polydocanol. Even you can use hypertonic solution.
Oh, yes.
Okay. Which may be available in the wards. The others may be, okay, you can use. What is the reason for emptying the veins before injecting? What is the main pathology behind it?
The veins gets compressed and the walls.
It produces aseptic inflammation and fibrosis of the walls. Because both the walls has to adhere, isn't it? So you have to empty the veins and inject and immediately apply a bandage. Okay. That produces aseptic inflammation and fibrosis and collapse of the walls. Okay.
Saniya, what is the technique of foam sclerotherapy called? Which we described just now?
Some names are there. Do you know the names?
No, sir.
See, somebody has, our Azharuddin is answering every question, sir.
Yes, sir, very good. Very good.
Captain of our Indian team, no, sir.
Sir, Srinivasan is our student. He is from our institute. Very active boy.
Azharuddin also is answering. Everybody is answering.
Tessari and Fegans.
Tessari technique.
Yeah, Tessari and Fegans.
Okay. You know, any latest, sir was asking you another question. Any latest treatment, or else, what is SEPS? SEPS, EVL, do you know, heard?
Yes, sir.
Yeah.
SEPS is subfacial endoscopic perforator surgery. It is a minimally invasive surgery. The perforators are localized by preoperative duplex scan, and through a small incision, a video endoscope is introduced into the subfascia. Through additional 5 millimeter ports using endodissectors, the perforators are dissected and ligated.
What's EVLA?
Endovenous laser ablation.
Very good, very good. Enough. If you know the names, enough. Okay.
Yeah. Now, sir, Srinivasan, sir, I think nothing is left for her to check her. She has prepared really
very good presentation, Syed, Saniya. The final thing is you tell me some complications of varicose vein and we close it. And we are not going to the depth.
The complications are superficial thrombophlebitis, hemorrhage, skin pigmentation, eczema, lipodermatosclerosis, varicose ulcer, periostitis, and rarely it can lead to DVT and equinus deformity.
Yes.
Why do they develop equinus deformity?
Because of the pain, the patient tends to walk on his toes, so there will be shortening of the Achilles tendon.
Why they start walking on toes?
Because that will relieve pressure.
Where?
In the lower leg.
This all my students know in my institute, more so my unit PGs, including Nishant. See, this is on a lighter side. Why do females wear high-heeled chappals?
Saniya, answer this.
Yes.
Answer everything.
Any reason? See, ultimately, the idea or the reason why people walk on 4 foot, it is not to show that they are tall. It is to lessen the work on calf muscles, so that the calf muscles will not become bulky. So this is the reason for females like wearing that, and so that they will not become bulky and slim looking. So they think that it is slim looking is a good looking. So here, coming to the varicosity, the idea why the person starts developing that is, he wants to give less work to the calf muscles area, requirement blood circulation and the requirement less work. One. Second, because there is a fibrosis around the ankle and there will be some amount of fibrosis around the tendo Achilles also.
Yes.
You got the point?
Yes, sir.
So it is automatically the nature's way of adjusting to the pathology what is going on.
Okay.
And it is common. We see a good number of cases. It is common in chronic varicosities. Okay, what is the difference between a chronic venous disease and a post-phlebitic limb or a disorder? Chronic venous disease or venous disorder or post-limb,
in chronic venous disease, there will be chronic venous hypertension, sir.
Okay.
In post-phlebitic leg, basically, it can present as a white leg or a blue leg.
Okay. You understood what is the reasoning, like why they are classified into two entities?
Yes, sir.
Which one you have presented now? Have you presented a venous disorder limb or a post-phlebitic limb?
Venous disorder limb.
Okay. Where there is an active disease in the form of either reflux or incompetence. If it is a sequelae of this disease, that forms the post-phlebitic limb in the form of either DVT or in the form of that post-phlebitic events, dermatosclerosis or a white leg. So they are all the sequelae of the disease.
Okay, sir.
Okay.
I think
anything
they're
else?
Also called phlegmasia alba dolens and phlegmasia
ceruleus dolens.
Okay. Wonderful discussion. Wonderful.
Kishan, we are on time. Kishan, we are on time. 1.5 hours.
Yeah, and we are. Nobody's looking at the time, sir. Here, except you. Nobody's looking at the time, sir. You are the first, maybe. Okay. How would it passed 1.5 hours? Nobody could recollect.
Correct.
And I think one thing I want to know. You answered everything. You know everything about varicose vein. Now tell me, how did you feel really, Saniya, facing two tough examiners, but sweet? How did you feel? I want the frank opinion.
We are not tough, Kishan. We are not tough. We are friendly and.
Kishan,
so that is, sir, we can make our levels higher, sir. By telling you tough, we are elevating our own levels.
No, Kishan.
We faced some tough examiners and we answered everything.
She did really well. She did really well. At par with a postgraduate, and she has really prepared for the presentation. She is not very casual. She is really prepared, and she has understood the pathophysiology and the disease. Really
Concepts, yes.
excellent, Saniya. Excellent.
Thank you, sir.
She has read really well, sir. She has read
Yeah.
really well.
And Sunny,
Wish
how
you
did
all
you
the
feel?
best, God.
How did you feel? Have you presented earlier like
It was
this?
a
Any
good
cases or
experience, sir.
surgery? Huh? First time.
I've presented in my college, sir. Here in White Army, it's first time.
Okay. Okay. Now, how did you feel? You feeling better? You feel nervous? In the beginning, how was it? And now, because you need to
Initially, I
motivate
was
others also,
nervous.
no? You can't keep on presenting.
Yes, sir.
Yeah. Now, how
Initially,
are
I
you
was
feeling?
nervous. Now I'm fine, sir. It was a good experience.
Which college are
So
you
you
from,
can.
Betty?
So you can.
BGS, sir.
BGS?
Bangalore BGS. It's just BGS, sir.
BGS Global.
BGS
Balagangadhar Nath
BGS
Swamiji
Global.
School.
Yeah.
Yes, sir.
Okay. Right, Kishan.
So
thank
now
you.
you can confident enough to present in any big platforms, right? Next.
Yes, sir. Yes, sir.
So this is a perfect ending for Teachers Day. Mentors are happy, students are happy, and we the audience also very happy. So it's a perfect ending for Teachers Day. I feel once again, sir. So my day is done. Okay, my intentions, purpose is solved and served, and I'm really happy. And thank you,
Thank you,
mentors.
sir.
My favorite teachers, Guru sir and Srinivasan sir.
Thank you.
Thank you.
Thank you, Kishan.
Thank you, sir.
Thank you.
Okay, thank you, sir.
Okay. Take care.
Thank you,
All the
Kishan.
best.
Thank you, everybody.
Thank you, sir. Thank you, sir.
Thank you, sir.